Get more from your cardiac PET imaging with Heartsea software from Bracco. Heartsea. See the potential. Introducing Dr. Nils Johnson, Professor of Medicine in the Division of Cardiology and Distinguished Chair of Heart Disease at the Weatherhead Center for PET Imaging, and Amanda Roby, Assistant Director of Technical Operations, also at the Weatherhead Center for PET Imaging, at the McGovern Medical School, University of Texas Health Science Center in Houston. Building an efficient cardiac PET program.
Hello, everybody. Welcome. My name is Nils Johnson from the University of Texas in Houston. So just a 3-hour drive to the southeast in case you have some time this afternoon. Welcome. This is a lunch and learn session. I can see that you all are busy with the lunch part of it. I hear the quiet sounds of noshing everywhere, people rustling your potato chip bags and such. And so we're going to begin with the second part of the lunch and learn, which is the learn part. So the way that this is structured is that there are 2 talks, each of 20 minutes. My colleague Amanda Roby is going to give the first one, and I will then do one to follow. And after those 2, we will have time at the end for questions. There's some microphones and such around the room. We can get some feedback and talk about whatever you want to. So without further delay, Amanda will come up and talk with us about building an efficient cardiac PET program.
Hi, everyone. We just finished up a nice lecture session in Next Door about building out your PET program. And so now I'm going to continue kind of that conversation on what you can do once you're kind of up and running. And so my disclosures, let's see if this is actually going to click. There we are. Is all of the honoraria gets donated back to our institution. And so first we want to talk about our PET cardiac service menu. So we have a lot of options, most of which I assume folks are doing relative uptake images at the least if you've already have PET going in your facility. If you're doing relative perfusion imaging, you're probably looking at adding flow. And both of those would be done with either rubidium 82 or N13 ammonia. And then underneath are in yellow are kind of the other available scans that are already FDA approved, like doing viability, sarcoid imaging and infection, all with FDG, and then other tracers that are in the pipeline. So if you're not thinking that you're going to be using a fluorinated tracer now, you might be looking at adding a fluorinated tracer in the next 5 years. So if you're building out a facility, some of these things that Aaron talked about is making it efficient from the beginning and taking into those considerations for your service lines. I want to talk about placement of the scanner. For those of you that have dedicated PET scanners, your folks are going in feet first, right? And unfortunately, whenever we added CT to the PET scan, we just started installing them like CT scanners when all of our patients are going in head first instead of feet first. So your technologist spends a lot of time doing this dance back and forth from the control room to the back of the scanner. And unfortunately, even with oncology, it means that as you scan your patient, the technologist becomes further and further away from them throughout the course of the scan and makes it more difficult to supply really safe patient care during the exam. So we're proponents of installing these scanners backwards. So if there's any CDL or TTG, GE, Siemens, United folks in the room, this is something that your technologists might be asking for. If you want to build efficient workflows, you want to look at reducing your steps. So installing them backwards reduces those steps, allows you to see the backside of the scanner where all the action is happening anyway. And in our facility, we even had a dedicated PET scanner in this bay before we switched to PET CT, and we did not have to adjust any of the shielding in the wall. So it can be done pretty seamlessly. So next you have this huge room here that you're going to put things in. And you have to keep in mind that there's always a lot of things that come with the machine. So you have equipment, you have mill work, you want a sink for hand washing, which is really nice if it can be located near the back of the scanner as well. Unfortunately, sometimes the plumbing is on the other side of the room, as you learn whenever you start to do construction. You want your doors to be wide enough to get patients in and out. So even say, oh, I'm an outpatient facility, regular, doors are fine. A lot of the scooters are coming through that are quite large, and having wide bay doors can be very helpful for your team. You have to get your ECG machine, maybe a generator in the backside of the system as well. You have to flesh out your control room, not only to house the computers that come with the scanner, but also computers that come with EMR or any other type of systems for processing in your facility. And then the one thing that my technologist group will not let me forget is trash cans. Trash cans are the equivalent of the printer being close to your administrative assistant. And I get repeatedly asked for more and more of these little black boxes for trash cans. You need sharps containers for hot and cold trash for sharps and storage. And looking at things like the ceiling tracks for IV pole hanging also helps keep things off of the ground and up in the air, out of folks' way. So what is, and then also you want to look at adding your audio visual equipment. So whenever you do turn these scanners around the opposite way, you need to have a way to visualize those pinch points as patients go in and out. So next, to kind of see what this looks like in practice, this is the view out of our control room. So as we look through the window, we can see the 12-lead ECG. You can monitor your generator. You can see that there's network and med gas up in the ceiling for easy access. And that after you add all of those things, it starts to become nice and crowded for us. And then the picture on the right here shows how this audio-visual equipment looks here from those pinch points from above. We can actually see these a lot better and feel a lot safer moving patients in and out with things like balloon pumps and chest tubes, et cetera, from this kind of bird's eye view of the pinch points in the scan room. Here's our other room, and you can see on the back cabinet, we even have like our phone. This is one that has the scanner equipment that is up underneath this millwork. So if you know in advance what you're buying, you can build your millwork around that extra equipment that you have in the space. And if your cardiologist happens to be very tiny, she might need a step ladder. So you never know. Next, thinking about infrastructure for F-18 tracers. If you do not have a shielded localization room in your facility, you might want to consider adding one of those. Those can be shared spaces. I love this chart that shows how the patient becomes less radioactive over time, which makes sense. But if you look to the right end of the chart, you can see that whenever you move about 6 feet or about 200 centimeters away from the person, you can actually get down to about background, even at time of injection. So building in enough space for your F-18 folks is important. And then your hot lab considerations. So you want to have all the available tools for your technologists from day one so that they're shielding their isotopes appropriately. They're moving, hot vials of rubidium, or they're shielding their N13 doses with PET-sized tungsten shields, and that you have available storage for hot trash as well. Next, we want to look at what kind of isotopes we're going to be using. So these short half-life isotopes really provide a lot of protocol efficiency. You can do 30-minute time slots quite easily, and it can improve your throughput. Both the rubidium-82 and N13 ammonia have a lot of flexibility in being able to produce doses on demand. So if you have something happen, you blow an IV, something doesn't quite go as planned, you have the ability to repeat those infusions, because within 5 to 10 minutes, all of your injected activity is gone and you have the ability to repeat. So the next thing that we want to talk about is what happens. You have all of these pieces that you've, garnered together, or your technologists are trained, you've had applications and software folks come in, you're ready to start scanning patients. And what we think that next step is to think about what kind of guardrails you should expect to see from your images that come out of your PET system. And so here's about 10,000 cases from our PET database looking at 3 different scanners. So on the left side, you have a 2D GE-DST that we're injecting on average around 40-45 millicuries. And then the next 2 are the 3D GE-DMI and a 3D United Mu550 that we're injecting about 30 millicuries on average. At rest and at stress. And so if we were to take the max and the min and say, okay, if you inject rubidium into a patient, you should get somewhere between around 11 to 2 microcuries per cc of uptake in the myocardium. You might say, well, it's a really large range, but I can guarantee you that if you have something systematically wrong with your protocol, like having the scatter correction turned off, having decay correction turned off. Those things change those from, 5 or 6 microcuries per C to 10,000 microcuries per cc, or down to 0.3 microcuries per cc. Maybe you have it selected for ammonia and not for rubidium. Things can definitely happen to your protocol either at startup or can sometimes even happen over time. Some physician might say that they want the images to look a little bit different. Things get clicked, and then very quickly you can fall into a very odd situation with your images. And so the other thing that our technologists look for is that typical drop or the typical increase in the activity from rest to stress on average. So on average, you're causing vasodilation, you're getting more radiotracer into the heart muscle from rest to stress. And so we see those averages go up from, say, 6.5 at rest to 7.5 at stress. And then for the 3D systems, around 3 or 4 up to 5 and 4. So all of those things seem to kind of pass the sniff test of data that's coming out of your system. Next, we can look at ammonia. The same thing holds true for ammonia. You're just causing the same type of physiological response. So you have a smaller range because you're giving less activity, right? So we gave on average around 15 millicuries of ammonia in our 2D systems, and we give around 5 millicuries at rest on the 3D systems, and then 10 millicuries at stress on the 3D systems. And we can see that same effect happen. It goes from an average of about 2 cc's at rest to 3 at stress. And then we don't just double because you've doubled the dose. We double the dose and a little bit more because of hyperemia, right? And you say, well, how on earth can I find that value? So there's 2 ways that you can do this. If you have software on your post-processing software, it might give you a maximum microcuries per cc readout like it does on the right side of this image, or you can just draw an ROI around a nice thick portion of the myocardium and receive some sort of readout, probably in becquerels, that you can then convert into microcuries. So this case showed 5.3 for the myocardium in the console and 5.4 on the post-processing software. So very similar. The same thing can be true for arterial input. So you want to make sure that the amount of activity that you're getting during that flow phase is being corrected appropriately, especially in a 3D system, and that you're receiving activity that makes logical sense. So again, very large range, 19 on the high end to maybe 6 on the low end for rest on a 2D system, and then around 11 to 3 on a 3D system. Now, for arterial input, we're looking for those values to drop a little bit between rest and stress. Those things not only let us know that maybe we've caused a good hyperemic response, but that we're also getting good boluses of tracer into the patient. Same thing with N13 for arterial input. We see, again, a smaller range because you're giving less tracer, but we see the same physiological effect where you get a drop in arterial input between rest and stress with that increased hemodynamics. And the same thing can be done in the workstation. This is an ROI kind of over the left atrium, and we get a value of 3.8 microcuries per ml. And depending on what your software readout is, the ROI mean at the bottom in the system also says 3.8, and then it occurs over 2 minutes. So the arterial input in this value is the 7.6, which is exactly what we see for an average over many, many scans. The next thing you want to do is look at a couple of different types of patients to not only validate your reconstructions, your protocol, your scanner, but also to validate the software that you're using to acquire flow. So this is a risk factor patient, pretty reasonable guy that had an outside echo that showed normal ejection fraction. He had a good blood pressure and heart rate response to diprotamol stress, and had minimal coronary calcium, no angina, no ST depression during PET stress, and actually came back caffeine negative. So for these, looking at all the literature in that tiny table on the right-hand side kind of shows you what we should expect to see for flows in patients. And these were kind of his resulting splash images. So you have the rest on top and the stress on bottom, because we perform resting scans first. And the piece that the red arrow is pointing to is that bowel uptake. So not only do we see that normal increase in activity on the left-hand side of the screen from rest to stress, but we also see a decrease in bowel uptake from rest to stress as well. It's another indication that you probably had a good vasodilator response. And then in our output of flow, at the top is the resting flow that is 0.82. So that's right in that wheelhouse of normal resting flow. He's able to increase flow to 2.3 at stress. Also a good response for a CFR on average of 2.8. So this patient, even though he's, a 71-year-old male with only risk factors, he actually ends up with over 70% of his myocardium as our normal volunteers. So that helps us know that those patients are coming out reasonably. Then the next one is going to be a transmural scar patient. So we looked at kind of the top end of the flow, and now we want to look down at the bottom as well. So we know from multiple research studies that our kind of average flow for transmural scar is about 0.3, probably anywhere from like 0.2 to 0.4. And so in this patient, they had an inferior MI in 2002, had been imaged multiple times, has a slightly reduced EF, AFib, and while their blood pressure didn't change a lot during stress, they had a nice heart rate response also, and were caffeine negative. So now we see in the tomographs, we can see that there is this, in fact, a resting and stress matched perfusion defect in the area of the inferior wall. And then whenever we look at the flow values, we can use an ROI tool to select just that territory of perfusion defect and receive the flow values for that territory that's selected. So that's what is underlined on the bottom left-hand side, that the rest flow mean for that territory is 0.2. So we're confident that our software is able to see the highs and the lows. So now that we are confident that the scanner's working, the software is working, now we can use some of these metrics to evaluate the images moving forward. So this next case happened just last week. One of my technologists said, hey, I pulled up what we call our QC image. So we use the first minute of relative perfusion data that comes out as our guide for matching PET and CT. So she looks at this first image at a minute and she says, oh, this looks like there's a lot of blood pool. I don't really know what happened. Look at this time activity curve. I've got this hump at the beginning. I've got this late hump at the back. Our typical kilocounts per second are around 1,000 on average. So she feels like she didn't get quite all the dose in, or the bolus was strung out over time. And that's likely why she's getting blood pool. So we decided the patient was pretty amenable. We'll go ahead and start a new IV on the opposite arm. Maybe it's the subclavian, maybe something's going on. We'll switch to the other side and try again. So by the time she was able to get an IV started on the other side, the rubidium generator was rejuvenated and we went ahead and re-injected. And now you can see we've actually doubled the maximum count rate. So before it was around 700, now we have 1,400 kilocounts per second. This curve is now very clean, and this first minute of relative uptake image now has no blood pool at all. So it was able to find that mistake early on. You can imagine if we were trying to do stress first, we don't typically get this image until you're about 4 to 5 minutes finished with your imaging. And so we wouldn't have known that there was blood pool likely until we would have given, say, aminophylline as a reversal, or until your adenosine or your regadenoson was completely gone. You would have been left with the decision of, well, maybe I'll start a new IV and maybe we'll give additional stressor, which is something that you could do, but seems a lot less or a lot more of a headache than just repeating resting images on the front end. This next one is a 71-year-old male that has a really extensive coronary history. They have reduced EF, they've had this AAA repair, they're end-stage renal failure with a fistula on the right side, COPD. They used regadenoson stress for this case, and they had severe calcium burden. You can see on the resting images on top to stress images, we do get a little bit of an improvement, an increase in counts between rest and stress, and no defect. So these were the resulting flows. And you can say, well, that's end-stage renal disease. We think that a resting flow of 1.4-ish is high, but not out of the realm of possibility for a renal patient. They are quite sick. So, you know, a CFR of 1.7 also seems to kind of go along with the history. And there's no blood pool in these images either. The relative uptakes look pretty good on first guess. But what if I told you that these were their resting and stress hemodynamics? Resting blood pressures in the 80s, and that continued to be in the 80s during stress. Now do we believe that these flows are still 100% valid? Probably not. Unfortunately, with this scanner, we don't get to look at those early images until we're basically already starting stress. So the technologist, whenever she went to sum up the arterial input phase, found that there was in fact a lot of anomalous blood flow patterns through the paraspinal veins. And so we have kind of documented proof that yes, that arterial input is getting smeared out over time. And they said, well, what other ways can we check to try to QC this? And unfortunately on this system, you don't get that same arterial input curve that you see on the other. And so here we get a throttle out where it just kind of blunts what we can physically see on the system whenever those images get relisted at 5 seconds a frame for the arterial input phase. So there were no kind of red flags or telltales in this case. So unfortunately for them, these flows were deemed to be unreliable. So this is rare, but it's important to recognize when it actually happens. In our clinic, we've had 2 of these over the course of this last year, and we're on track to do about 1,800 cases. So it's a pretty rare occurrence, but definitely important to note when it does happen. Now, I don't know if you noticed on one of these charts, there's this tiny little outlier over here on our 3D system that looks like it's outside of that lower minimum. And so I went back and looked at it because I wanted to make sure we give you guys an example of what can happen and maybe how robust PET flow can actually be. So this is a patient without any risk factors or without any kind of clinical events over the last 10 years. They only had risk factors. And it was just a follow-up scan for a research protocol. So we can see at rest, their maximum uptake was only 0.8. So that looks even less than ammonia, right? So we should expect to see a lot more activity. And in fact, we do see a really significant amount of activity for stress that seems within the realm. So next we think, oh, well, maybe something happened with that. But whenever we look at the arterial input, it doesn't look like there's any anomalous blood flow patterns that are happening. And in talking with the technologist afterwards, she was like, oh, I remember I went in to start stress and the physician couldn't push the dipritamol, and it had to do with the way his arm was kind of kinked up. So we had to move his arm all around, but we finally got it open, and then we just kind of went along with our business and everything else went fine. And so what must have happened is at some point during the rubidium infusion, they either kinked their arm or moved it so that the subclavian caught all the rest of that activity and it didn't continue to trickle down into the myocardium. And in this case, the one from 2022 is the one with the significantly reduced amount of injected tracer. And we see that the flows are actually quite similar to their resting flows from 2014, and 10 years ago, their resting flows were also the same. So while things might happen and fall outside of your guardrails, as long as they make sense clinically, it does tend to be very robust in its calculations. The last one is I want to show you an example of splenic switch off. So these are the resting images, and you can visually see the spleen down there at the bottom with the red arrow. And then at stress, you can appreciate that that has been kind of turned off quite a lot. And these were the resulting flows. So resting flows of 0.5 globally, stress flows only 0.8, which shows that about 71% of the myocardium is less than 1. And so as a stress flow less than 1 is kind of your threshold for severity, this definitely drops into that category. And the CFR of 1.6 also puts you into that high risk bucket, right? So despite the splenic switch off, we found that this patient was in fact caffeine positive. So they tested at 1.6. And so we elected to repeat that exam. And so whenever they came back with 4 days of decaffeinated life, we found we were able to increase that stress flow by about 70%. So the caffeine in the presence of splenic switch off still impacted these flows very significantly. And it took this patient from maybe falling into a high risk bucket of microvascular disease with no perfusion defect, into a completely normal scan now that they're actually caffeine free. So in closing, I'd like to say that it's really this technical team standing with me in the back that supports all of those pieces to make sure that whenever we deliver a folder to the physician group and ask them to make a clinical decision based on our data, that it is accurate, it's been done efficiently, and we're making sure that we're validating all of our scans with those benchmarks in every single case. So thank you so much, and I'll turn it over to Dr. Johnson.
Right, now I get to vent my spleen. So these are the disclosures. As Amanda was mentioning, we generate some PET software, that stuff that is our institution's disclosure, really not mine. And then also I do a lot of speaking on various topics. So there's about 4 parts to this. The first is kind of a philosophical overview about why we do imaging. The second is some updates on some of the choices that we've made for our particular flow software package. Then I'm going to talk about why it's important to do resting pictures. And then the last piece is why it's important to make flow measurements. This slide and the slide after it both make the same point, and that's that one of the challenges of imaging is and that is often the pictures are normal. You can see here in this prospective registry that 75, basically 3 out of every 4 scans was normal in this cohort. So most of the images end up being normal. And in fact, there are probably some labs where that number is not just 75, but like 90+%. So a lot of the time things are normal. The flip side of it is that there's this, I would say, ignorance. That is, even at the top end, you can see when scans are moderately or severely abnormal, only about half of the time did the patient go on for invasive angiography. And you say, well, okay, maybe that was just unique to this particular registry. This is a similar type of effect when you look at this randomized trial of patients who had established coronary disease and were undergoing a SPECT and PET imaging. About 30% of the cohort or so had an abnormal scan. That means 70% had a normal scan. And when you look at the subsequent rates of revascularization, even when there was something really severely abnormal on the PET scan, only about 1/3 of them underwent revascularization. And you compare that when the PET didn't have any of that, you still see that 10% or so of them underwent revascularization. So it's difficult sometimes to understand these decisions downstream. And I would say that that's a pattern that could be improved probably through case selection. And I also think there's an opportunity for how we talk to the referring physicians about what to do with the results. And there's lots of philosophical differences in the world. Here's one in what we should be doing as the imagers who are writing the report. It is our belief on the left-hand side that it's important to take all the clinical data and make a recommendation for or against invasive procedures, because that is what the person who's ordering the test is asking. Now, on the right-hand side, you will see that that philosophy is not a unanimous one. This is a document from the ASNC group that came out recently, highlighting that, well, maybe there's lots of other things that are going into the decision, and so we should be more circumspect. In fact, the ASNC group puts forward this particular report, which is one that was developed to develop a patient-centered tool. And you can see that a big part of it down at the bottom is talking about having your risk of significant blockages. I don't know what that means. I'm a cardiologist. I'm an interventional cardiologist. I do PET all the time. This is not how I think about coronary physiology and coronary treatment at all. And I'd like to show you 3 examples from my own practice and view them through this lens of our philosophical duty as imagers. So this is a patient of mine, and you can see the PET images on the coronary flow capacity map show a fairly moderate to severe defect in the mid-LAD distribution, and then there's a scar in the circumflex distribution. This is a patient who had, in hindsight, what was probably a subclinical MI. I didn't really understand that's what it was at the time, and has been having angina since then. He's a very active racquetball player. And so with this kind of report, you can see what we say at the bottom. There always is this preference about depending on clinical judgment and informed patient preferences. I hope that's what we always do with our patients. But the physiology here tells us that you're going to find a mid-LAD lesion that would be appropriate for revascularization, but you should stay away from the circumflex because that's a transmural scar, right? That's not something where there's some kind of physiologic debate about it. That just is what it is. And you need to communicate that very directly to the referring physician so that they can understand what they're going to see in the lab, what are targets for treatment, and what they should stay away from. So that falls into the green go category. What about this one over here? This was a patient who had some atypical symptoms, saw her in clinic. She had some, I think, subclinical coronary calcium. And you can see findings favor continued medical therapy for a variety of reasons, right? Normal uptake, EF's intact. She didn't have angina or EKG changes during vasodilator stress, and she has intact coronary flow capacity. There's not some kind of room for argument here. This isn't about percent risk of blockages. This isn't some kind of, there are different ways to treat this case. This is someone who does not need invasive angiography and can be managed medically. However, there are cases that do fall into the yellow light, right? Sometimes stop, sometimes go. This is a clinic patient of mine who I just saw a week or 2 ago who has angina. You can see she has 4 out of 10 clinical angina and also had ST segment depression during vasodilator stress. However, her defect is of modest size. It's in a more distal distribution. Her EF is intact and coronary flow capacity isn't severely reduced. And so therefore I say, you know what? You've got options here. You could have a trial of medical therapy, or you could go after this. It depends a lot on patient preference. And indeed, she actually decided for conservative management. So there are cases that fall into this, but again, those are ones that we can identify with all of the data and say such in our reports. One of the things that you've noticed with Amanda's slides and with my slides is that we're showing you the heart through what I call this topographic map. Topographic maps are like when you take the globe that is the Earth and you flatten it down on the screen, but you don't want to make Antarctica too big. And that's the reason that we do the same thing with the heart. You don't want to make the apex too big, right? The apex is like Antarctica. You don't want to make that appear distorted. And this is the best way of doing that. The other important reason for choosing this display format is that it links with the clinical consequences. And that is our goal, is to link the perfusion defects to coronary anatomy so that we can provide rational insights on what to expect in the cath lab and what are targets for vascularization. And because you're looking at a topographic map, there are well-established atlases that we've put out that reflect the coronary distribution. And you'll notice on many of our pictures that we're showing you, we actually kind of have this facade or ghost view of the coronary arteries. Again, there are different color schemes in the world, but I just show you ours so that as you look through our pictures, you understand what the uptake scheme is that we're using. You'll notice one of the other choices that we've made is to not put some kind of rigid number of segments. I love the number 17. I was born on the 17th, but nothing in the heart is based on 17. And so this number has nothing to do with anything. And coronary anatomy can be almost infinitely variable among patients. Take, for example, this particular example here. On the left-hand side, I'm showing you the Heart-C data boxed into these 17 segments. And on the right-hand side, where we just use a region of interest tool to delineate what is a severe defect in the RCA distribution. Now, take a look at that segment over down there at about I guess it'd be like 5 o'clock, 4 o'clock, somewhere there, where it says 0.47. You see that segment on the outer wall? Now take a look at it. It is a segment where the average value is 4.7, but it's average of 4.7 only because half of it's red and half of it's blue, right? Again, when you box things into rigid segments that don't match up with the coronary anatomy, you end up then trying to say things that are this kind of weird hybrid, right? It's like all people in the world have like 2.5 children or something like that. You can't have 2.5 kids, you got to have 2 or 3. It's the same thing with coronary anatomy. And so all of these design decisions that we've made have gone into our philosophy of what is behind a flow package. People often get very hung up about the exact flow modeling calculations. And as someone who did physics and computing in the past, I love that stuff. No one loves it more than me almost. But that's only one of many, many components that go into understanding if your flow package is able to validly produce numbers and can display that information in a way that allows you to make good clinical recommendations and has been validated, really, I'd say, across the spectrum of flows and of different vasodilator medications. It's interesting, if any of you got to pay attention to some of the stuff coming out of London last week at the ESC meetings, you'll notice that coronary flow capacity is now in the guidelines. You can see over there several of the highlighted passages from the new European guidelines on coronary flow capacity. And the other piece, which I think even goes beyond what the US guidelines have said, is that when we talk about patients, it should be preferably PET scanning that we should be doing. So I'm glad to see that ESC has done both of these things. So I promised some cases. Let's start off by talking about resting perfusion and the need for it. And I'll show you 2 cases and contrast the outcomes and clinical management of them. So these are 2 patients, top one, bottom one, and I'm showing you both the tomographic and topographic images. You can see that at stress, they're fairly similar, right? There's a large size defect in the inferior and infralateral region, and it's of similar severity, maybe a little bit worse for the patient on the bottom. So is this information by itself enough to understand how to manage these patients? The first patient is a 74-year-old man who has a new onset angina, had a very distant, I think, balloon angioplasty of his right coronary artery, came in with very classic symptoms, shoulder pain, chest pain when he was exerting himself. You can see that during adenosine stress, he had both ST segment depression and moderate angina, and his resting pictures are normal. Right, so what's happening in him is that he has a severe RCA lesion, and you can see the anatomy down there at the bottom. We were able to stent that successfully, brought him back for a repeat PET scan, and the resting pictures are the same, but the stress pictures are obviously dramatically improved, and his angina went away as well. That's the key thing. The second patient is a 65-year-old man whose internist didn't read the guidelines and has been doing totally unindicated EKGs every year. But you know what? When you do totally unindicated stuff, sometimes you get lucky, and he got lucky. And what did he find? Well, he found that one year he had R waves in the inferior leads, and the next year he didn't. He had Q waves there. And the guy has a lot of very chronic shoulder pain issues, a lot of arthritic issues over the years. And so he got sent to us for evaluation, but nothing that could be described as angina. And I'm showing you here then his rest pictures and his stress pictures. You'll see that largely most of the defect is quite fixed. There's a little bit of reversibility in the lateral region. That's due to a CTO of a second OM branch that we did a CTA on him. But the RCA itself, transmural infarct, you can see that on the PET pictures, really matched deficit of perfusion tracer and metabolic activity. So to come back to these 2 cases, they may look very, very similar at stress, but the patient up top, because he has normal resting perfusion, has an ischemic RCA, needs PCI, whereas the patient down at the bottom has infarcted his RCA, and there's no need to do an angiogram on him. You can just medically treat that area because the infarct has already completed itself. So look the same at stress, totally different management because the resting pictures are different. So let's then take, in some ways, the mirror image of that. And these are 4 stress pictures. And you can see that all 4 of these patients have normal uptakes. I'm showing you the, again, tomographic and topographic views. I'm not trying to throw any curveballs. Every one of these patients has a normal ejection fraction. All of the caffeines are negative. So they had, an appropriate reaction to vasodilator stress. So are all 4 of these patients the same? All right, let's take a little deep dive. The first patient is a 74-year-old woman who's had prior PCI. You can see there her patent stents. So she got cathed, I think, a year or 2 before the PET scan. She's had some exertional dyspnea, limiting fatigue. During vasodilator stress at peak dipritamol, you can see she has ST segment depression, and she also had moderate angina. So her stents are open. She has normal uptake. Why is this happening? Well, we can see over here from the flow quantification that she has a reduced CFR globally, right? Her CFR is 1.8. It's not low because of caffeine. We've got rid of that. So this then is actual reduced coronary flow capacity from microvascular disease. That's what causes her symptoms during dipritamol. What about this woman? So she's 66, has frequent palpitations. On the PET CT, there was no coronary calcium. Her ejection fraction's normal again. Caffeine is negative. Her CFR, 2.7, something like that, really high. So it's not like there's any blunted flow capacity here. But yet look what happens to her EKG. So during vasodilator stress, peak dippy, she has ST segment depression, and she develops 7 out of 10 angina. Why is she having chest pain and EKG changes despite fantastic flows and even intact subendocardial flows? And this is a pattern that, to be honest with you, I'm not sure that has been well appreciated, probably because of the tools that need to understand it haven't been well developed. But it's someone who has ST segment changes despite all of those pieces that I mentioned. And I think this is probably a stretch mechanism that as she develops hyperemia, that then causes myocardial stretch. And stretch is another one of our nerve sensations that can cause patients to have symptoms and also change the repolarization properties of the myocardium as well and cause the EKG changes. What about patient number 3? Well, a 68-year-old woman who had angina and dyspnea for several years. She's obese. Her BMI is 35, intact DF, no significant valve disease. And during dipritamol stress, she had severe angina. You can see that she was recently cathed. Her coronaries are normal, and her CFR is also normal. So it can't be microvascular disease because the CFR is okay. It's not epicardial coronary disease because the coronaries are all right. So why is she having severe angina with dipritamol stress? And the reason is that she has subendocardial ischemia. So if you look at the cross sections, if you look at the donuts of the heart on the right-hand side there, you can see if we trace the subepicardial border from the rest pictures onto the stress pictures, there's that area of blue that's almost circumferential in her case. That's the area of the myocardium, the inner layer of the donut that doesn't get enough blood flow during stress conditions, even though transmural flow on average is intact. And so this is subendocardial ischemia as an explanation for her. The last patient of that 4, of that quartet, is a 56-year-old man who has fairly severe angina. You can see his risk factors, very dense calcium on his CT. He was put on a Bruce treadmill protocol, and you can see he developed very dramatic ST segment changes after just 5 minutes of exercise, and yet has fairly normal stress EF. And you can see also his perfusion pictures at rest and stress were normal as well as far as uptake goes. Now, what's going on with him is he has severe multivessel disease. So you can take a look at his coronary flow capacity map. There's significant segments, over 20% of the heart is green or blue. And you can see when he had his angiogram, he has really multivessel coronary disease. And so we bypassed him, and then we brought him back. And here is his repeat PET scan after bypass. So his angina got better. That's fantastic. His uptake images are about the same because they were always good. But look at his flow. The coronary flow capacity map goes from having all that green, touch of blue, lots of yellow, and it really shifts up to orange and red. Importantly, when you look down at the bottom, the key metric there is that his global stress flows have basically doubled, right? He used to be able to go up to stress flows of about 1.2. Now he can go up to 2.4. Of course, you might kind of get confused if you look just at the CFR alone because his resting flows changed, but that's the reason you use coronary flow capacity, just like the ESC guidelines tell you to, and his coronary flow capacity has improved dramatically. So how often do these patterns happen in practice? So Amanda and I have been showing you some of the data from our large PET database. About 10,000 dipritamol scans. When you look at our rate of fairly normal uptake, and again, I can tell you exactly what that means quantitatively, but about 2/3 of patients have relatively normal uptake images, like the ones I've been showing here in this case. And when you take that 2/3 and you divide it into 4 groups, that is flow intact or reduced, and is subendocardial flow intact or reduced, you can see the distribution. That is that actually, when you have a normal uptake scan, most people have intact coronary flow capacity, right? You can see that it's something like a 70-30 split, right? 70% of the time, coronary flow capacity is intact. Most people, though, who have intact coronary flow capacity do shell out the subendocardium to some extent. And you can see that patients who have reduced coronary flow capacity and intact subendocardium end up being the least common of the 4 different patterns. But again, to take these 4 different patterns and link them back to the cases that I started off with, who again, all look the same if you just look at stress uptake images and you don't look at flow. The first person was an example of microvascular dysfunction, right? You can see that that is actually an uncommon mechanism. Maybe about 4% of the cases fall into that category. So microvascular disease exists, but it's uncommon. The second is this hyperemic stretch phenomena that I talked to you about. I don't think it's been very well described in the literature, but you can see a nice example of it there. That ends up being the second least common pattern. The really ones that end up dominating things are like subendocardial ischemia, number 3, that ends up being the overwhelming number of patients, 50-some%. And then you can occasionally have severe balance disease that needs revascularization. So welcome to Texas. Thank you for listening to us, vent our spleens, and we will then, I think, have 20 minutes left here at the end to talk about whatever you want to ask us about. Thank you. Okay, there's some microphones there in the center. We can also pass microphones around. I think there are people lurking, but if you want to ask questions, if you want to come up and accost us, whatever works for you. Take this over here. Might as well just sit around and get to watch us eat. Yes, Dr. DeKemp.
I'll get it going. Wonderful talk, as always. Thank you. I'm happy to see the QA procedures and terrific clinical examples. Very enlightening. I wonder if you can tell us, are you using at all kind of based apex gradients in helping to distinguish between other subtypes, kind of diffuse epicardial disease or other pathologies?
It's a good question. We have some quantitative software to look at base to apical perfusion gradients. I must say, now that we've had our subendocardial quantification, that's become less important for identifying diffuse disease. A lot of patients who have diffuse disease will have some amount of subendocardial shell out that we see. So we look at it in some cases, it's there, but now that subendocardial quantification has become routine, I would say that's largely become a bigger sign that we've focused on for identifying diffuse disease. The second thing that I think has changed technically is a lot of the base to apex gradients were done back in the dedicated PET era. Now that we have PET CT, you identify a lot of people who have diffuse coronary calcifications. And so that's obviously another clue that tells us that patients have diffuse but non-obstructive disease. So I'd say those 2 changes, the addition of CT where you see the coronary calcium and then the subendocardial shell out, have made it less common that we need to look at the base to apex gradients. But there are some cases where it's still useful. All right, I paid him to ask that question. It was a great question, but he was the plant. You always got to have one to kind of kickstart the momentum. I can just see it. See it now flooding in. Oh, we got to move her. Unless he's going to get some extra food.
I must say, the first time I heard about this myocardial stretch when you're giving a vasodilator. Explain that to me, because the first time I heard of it. And I'm not sure what's the physiology behind it and what's the science behind it.
Yeah. So you have a garden hose, right? you ever had watered your, so you have garden hoses, I do anyway. So in Texas, because the summer lasts basically all year round, we use our garden hoses a lot. And when you go out to your garden hose and you turn the tap on at the house, what happens to the hose? It swells up, right? It stiffens. Everyone's looking at me like I'm the crazy one, but you go look at your hoses, that's what happens. So this is called the garden hose effect. And what you've done with your garden hose when you turn the tap on the house is you've increased the amount of blood volume in your myocardium. And that's the same thing that happens when we give patients vasodilator stress. The myocardium swells as the blood volume increases. If you've looked at this, I don't know if you've ever done animal work or other things like that, or been in the operating room when they've given vasodilators, you can also see this phenomena. And so that stretch phenomena, again, garden hose, if you look in the literature, I'm not just making this up, this is a technical description of the topic as well. That's really been longstanding. If you go back to the 1980s, people have looked at this garden hose effect for the myocardium. And so the question is, what does that garden hose effect, what does that thickening of the myocardium do? And in some patients, like the one that I showed, not very often, but sometimes that can, I think, provide the explanation for these ST segment changes and clinical symptoms that we see in patients with vasodilator stress, despite really good hyperemic blood flow and despite normal blood flow to the subendocardium. Again, we're hoping to get this out in the next month or two for a more detailed analysis. But when you look at the kind of patients who have this, it tends to be patients who don't have coronary disease, and there tend to be some other demographic features for them, often smaller, just body masses, and women as well. So you're right, not a pattern that I think we talk a lot about. And the reason I think is that those kind of people, unless you have the ability to make sure you have a quantification for subendocardial perfusion, often will get lumped into that bucket as well. Or if you don't have a method for identifying coronary flow reserve, people will call them microvascular disease. So I think it's a group that in a way has been hidden in plain sight. People have been seeing these patients, thinking that they're microvascular, thinking that they're subendocardial ischemic patients, when actually neither one of those is an explanation for the particular type of patient that I showed there.
Thanks for a great talk. Couple questions. One is for that group that we just talked about. How do you treat them? Is there anything that you have noticed in your own practice, or is there anything to alleviate their symptoms, which seem to be real? Second question is,
I'll just do it one at a time. Otherwise, my short-term memory will fail me. I used to have a great short-term memory. At least I think I did. I forget, actually. So you're talking about the hyperemic garden hose patients.
Yes.
Yeah.
Yes.
So what do you do with the garden hose patients? Ultimately, the only things you can do for them are to try to reduce pressure rate product. At least that's what I try in some of them. And in some of them, I also have tried, again, without a whole lot of data behind it, sometimes almost like aminophylline or caffeine medications to try to see if that blunts this, in a kind of proprioceptive stretch reaction. Yeah. But yes, good question.
Second question is kind of with the emphasis on coronary flow capacity, as opposed to just CFR alone. In reporting, do you think that we should be using coronary flow capacity, coronary flow reserve, both? Well, how do you think that impacts reporting?
Well, let me just come back to that one patient who we did the bypass on, right? So if you just look at CFR in that patient, you couldn't tell if I had done bypass on him or not, right?
Yeah.
So right there, you know that CFR can't be the answer. Because when you put someone and rip open their chest and put 4 grafts on and you can't tell the difference anymore, whatever you're measuring can't be the full answer to it. And the reason that CFR looks to be the same in his case, 1.8, I think it's 1.8 the second time, is because rest flows can vary so dramatically. And so when you understand that, then coronary flow capacity is the consequence of it. And you can see how dramatically that changed, right? You look at those 2 color maps, boy, it's night and day. And so you don't need to, I guess your question is, do you report both CFR and CFC? In the body of our report, we do talk about what the rest flow is, what the stress flow is, and what the coronary flow reserve is. We also report out the different colors for coronary flow capacity. The only maps we provide to the end user, though, are the ones that show the integrated coronary flow capacity. Because if you just, put CFR 1.8 up there again, that would not allow the person to understand what's happening.
One last question. I know it's controversial and not really recommended. In this model, with this coronary flow capacity model, is there any room, I don't do it myself, but any room for rate pressure product correction, that sort of thing? Or because supposedly that helps correct for rest flow issues, et cetera. I personally don't do it, but just what your thoughts are.
Yeah, fascinating. I got all into resting flow. We were at this thing in Jack looking at auto regulation. And so when you try to answer the question, why do you have a resting flow of 0.97 and I have a resting flow of 0.86 or something like that? Like, how can we figure out what's driving someone's resting flow? And if you go back, obviously, to the deep physiology, it would be myocardial oxygen consumption, which is driven then by preload, afterload, contractility, and then there's probably some basal oxygen needs that are made just to kind of, supply the electrical system and all the other kind of apparatus of the heart, right? Practically, though, when you try to measure those factors, it's really hard to measure inotropy in patients. We don't have, I would say, a non-invasive technique for doing that. Afterload, we do with blood pressure or pressure rate product measurements. And so people have gotten really focused on pressure rate product. And indeed, it accounts for the largest single explanatory piece of resting perfusion. Probably allows you to understand about a third of variation in resting perfusion when you look at people. But still, it only explains a third of it. So the other 2/3 not explained by pressure rate product. Another factor that accounts for resting perfusion is that women have higher resting perfusion than men. Why? I don't know. If anyone knows, please tell me, because I've been meaning, I hope I don't have to die before I get to figure that out. But, that's a fascinating gender difference that has been seen in many different studies. The other thing that drives up resting perfusion consistently is patients who have end-stage renal disease or advanced kidney failure. Is it perhaps patients who have fistulas? There's kind of always a little bit of shunting going on, and that drives it up. Is it something else that's happening? It's not just pressure rate product by itself. Even when we adjust for pressure rate product in those patients, end-stage kidney disease still ends up explaining a reasonable amount of why someone's resting perfusion is higher. And then also body mass index also explains some of it. You think about why humans have a much lower perfusion, say, than mice. I don't know if you guys know this, but mice have a perfusion that's like 5 or 6 times our perfusion. And some of it is probably just the way blood flow delivery scales as you as an organism change over orders of magnitude of body size, right? Whales have very low resting perfusion. So all of those are ways of saying that in an individual patient, if I looked at you and then someone said, hey, what's his resting perfusion? Well, I could kind of do those things. I could say, well, his kidney function and his blood pressure and all these other things. I'd be able to explain about half of the resting perfusion variation. I can explain with those 5 factors that I just mentioned. But that means the other half can't be explained through easy, non-invasive measurements. I assume if you let me put catheters in your LV and I could measure your dBdt and I could figure out your inotropy, fair enough. Then I could explain all of it. But just in the PET lab, when you're trying to figure out what you can easily explain, you can only do about half. And that seems to me to be something that if your goal is to understand variations in a population of patients that you're taking care of, right? Like you're doing a retrospective or prospective protocol and you have 400 patients and you're trying to make everyone look the same, then adjusting for all those things might be reasonable. But on an individual patient level, the noise is just too great. Again, you can't explain about half of the variation that you see. And so I think that the more reasonable way of dealing with that physiologic challenge is to use something like coronary flow capacity, where you get 2 bites at the apple. You get stress flow and you get coronary flow reserve. So that's the way how we account for resting perfusion differences. Yeah. Yes.
I have 2 questions.
Okay,
First,
we're going to do them one by one, just by my short-term memory
Okay.
thing again. Bear with me. Keep going.
my understanding about subendocardial ischemia was it's kind of associated with wall thickness, like a hypertrophic cardiomyopathy, hypertensive cardiomyopathy. Have you described it as something related to this, or you have seen in like a normal wall thickness as well?
It can happen to anyone. It can happen to anyone. Now, you're right. The extremes, like think about hypertrophic cardiomyopathies with, a 2.5 centimeter thick ventricle, right? Those are the ones that are most easy for us to understand, and also historically have been the easiest to image because it's easier to take pictures of something that thick and see if it shells out. But it's a phenomena that can happen with any amount of LV wall thickness. And again, this comes down to the fact that the subendocardium is vulnerable for several reasons. One reason is that your heart only breathes in diastole, right? So, when the heart is squeezing the subendocardium, it gets crushed, right? As LV pressures go up and as the myocardium thickens. And so blood flow to the subendocardium in everybody in this room, while we have been talking, blood flow to your subendocardium has stopped every single heartbeat when your heart contracted. But then again, when you went into diastole, blood was able to get back into the subendocardium, right? So what happens then is that the subendocardium is finely balanced. It doesn't take too much tachycardia, increased LV filling pressures from hypertension or aortic valve disease, or even during diastole, high LV filling pressures from diastolic dysfunction due to all of the things that drive diastolic dysfunction. Those are all forces then that can end up tipping the balance to the subendocardium such that you get subendocardial hypoperfusion. Interestingly, a lot of people can tolerate subendocardial hyperperfusion and not have angina and not have ST segment change. Again, just think of the enormous amount of aortic stenosis patients who don't have angina when they walk, right? Even though their LV filling pressures can be really high, 200s, 250s easily in your LV when you've got severe aortic stenosis and a hypertrophic ventricle, but yet, angina is not something that every single AS patient has. And so it's interesting that the subendocardium often has an imbalance. You can often see subendocardial hyperperfusion, but it's not that everybody then has symptoms from that.
Thank you. And how do you classify non-obstructive diffuse atherosclerosis? Is it like do you think part of this four group, you can put it somewhere like maybe against subendocardial ischemia or?
Yep. So if patients who have, again, there's a spectrum, but if you think about the worst end of the spectrum, the people who are at the worst end of the spectrum are going to be patients who have a reduction in coronary flow capacity, and almost always they have subendocardial shell out. So it ends up being that group, again, the little 4x4 box. It was the yellow group over there. About 20 or 25% of our PET scans that have normal uptake fall into that group, where they have reduced flow and they have a subendocardial perfusion defect. That's really the markers for diffuse atherosclerosis. And again, if you just have mild diffuse atherosclerosis, you might have intact coronary flow capacity. So again, it's a spectrum. I'm not trying to say that, but if you have to choose those dividing lines, that would be the group where diffuse coronary disease falls into.
Thanks so much.
Question.
Are there any differences between the vasodilators regarding the increase of the magnitude of stress MBF from your experience? Like are any differences between the CFR if you are using the regadenosin or if you are using the adenosine? Thank you.
That's when I paid her to ask that question. And the reason I did that is because we wrote a whole paper on this. So we got obsessed. So maybe about 10 years ago, I got obsessed with regadenosin. And Amanda was very patient with us. We would say, hey, listen, we want you to wait, 50 seconds and then inject it. And she'd run like 20 patients. And she'd come back and we look at it like, okay, now we want you to wait 80 seconds and inject it. And she'd go away, she'd run the day, she'd come back. And so we have this whole series where we were trying to look at the pharmacodynamics of regadenosin hyperemia. Pharmacodynamics is what the drug does to your body, right? How does flow increase after you inject regadenosin? And then eventually, of course, it has to decrease again as your body gets rid of the regadenosin and the hyperemia wears off. It turns out that there's there is a plateau in there where regadenosin seems to peak. And again, if you look in our paper, you'll see exactly where this happens. Even at the peak, regadenosin is only about 90% of dipridamol or adenosine. Now, you might be surprised by that. I can see the surprise on your face because you say, wait a minute, when you're in the cath lab and you've got a pressure wire down and you give regadenoson, you hit the same FFR that you do if you use IV adenosine. So how can you hit the same peak, but tell me that the flows are lower in the PET lab? And the reason is that we need, it's one thing to hit an instantaneous pressure peak in the cath lab for like a couple cardiac cycles. It's another thing to have that hyperemia sustain itself long enough to inject a radio tracer and take pictures of the blood flow in the myocardium. And that's why it's a little bit lower in the PET lab. So regadenoson is like 90% of, diprotomol adenosine. It's like, we don't have it anymore, but they said like Coke Light, it's like kind of like Coke Light or something like that.
Thanks. Do you see any difference in terms of when you have low coronary flow capacity on cardiac motion? Is there a direct link between reduced coronary flow capacity and reduced segmental motion in the same area or not?
And when you say motion, you mean
systolic contraction or
like ejection fraction or just?
Yes, or thickening, low segmental thickening of the myocardium in the same area.
There is a population trend. Patients who have cardiomyopathies tend to have worse flows and therefore lower coronary flow capacity. But there's an enormous amount of scatter. If you just came to me and said, this is the coronary flow capacity, what's the ejection fraction? It could be all over the map. And if you said, oh, here's the ejection fraction. So there is a very weak population level relationship between the two, but there's no fundamental patient level relationship that's meaningful. And the reason for that is autoregulation. That is, your body is able to adjust blood flow to the heart muscle over a very wide range of perfusion pressures. And this has been something that they've seen in humans and animals, all other kinds of things. You can get down to coronary perfusion pressures of about 40 or 35 millimeters of mercury before you have resting LV dysfunction from reduced perfusion. Ischemic cardiomyopathies actually are really rare. It's hard to produce them. You have to try really gosh darn hard. Most patients who have resting LV dysfunction don't have an inflow problem. They have non-ischemic cardiomyopathies or infarct cardiomyopathies.
I mean, ischemic induced motion dysfunction.
Yeah, again, uncommonly happens. Uncommonly happens. I can show you it as I can show you cases where people stun and all those kind of things. But if you just look at patients and the relationship between, say, EF augmentation and coronary flow capacity, again, there is a relationship, but it's so weak that you wouldn't be able to explain most of it through that mechanism by itself. Okay. Yeah. All right. I see 26 seconds left on the clock back there. That means it is time to go to our next session. Thank you so much, everybody.